All right, next up is Bryan Krueger, one of my partners, and someone I love to call and and ask for advice. So he's going to talk about artificial intelligence in spine surgery, and you're going to hear a lot more about the unit and how he incorporates it into his practice.
All right, thanks, Zach, and thank you all for coming today. You know, this being our first time doing this, it's quite a great turnout, and so far the talks have been quite awesome. It's going to be hard to kind of follow all that up. Something that I've gotten involved in the last year and a half is this idea of AI's role in deformity correction surgery. And, you know, when you hear the term AI or artificial intelligence, especially when it comes to its role in surgery, I think our minds go straight to thinking about robots and robots performing surgery. You know, as a surgeon, like, oh, am I going to have robots take my job? You know, like, and you know, this is just kind of the mental image that we get. But I hope this talk kind of shows more the reality of the situation. We're probably hundreds of years away from this, but who knows? Some initial thoughts. You know, you can look at, you know, if the idea of AI intimidates you, you know, just a background. I studied biology in college. I went to med school. I don't have any background in computer technology, software technology. I used to say I'm pretty computer illiterate. So, you know, it kind of makes me feel good when the Vice President of the United States says AI is kind of a fancy thing. You know, first of all, it's 2 letters, means artificial intelligence. Well, we're all on the same page. That's where we all start with that statement. Okay, and so then we can all kind of grow together. And so, you know, if it's intimidating to you, you just got to start somewhere. You know, Elon Musk is a pretty prominent figure in our culture. He's got a lot of pretty rational opinions, I would say. He's a little bit nervous about the blowing up of AI, and he says, "I'm increasingly inclined to think that there should be some sort of regulatory oversight, maybe at the national and international level, just to make sure we don't do something very foolish." I mean, with artificial intelligence, we're summoning the demon, and he's very concerned about us creating some sort of extinction event for humanity. Ginny Rometty, she's a former CEO of IBM. I think she put it the best when she said, "Some people call this artificial intelligence, but the reality is that this technology will enhance us. So instead of artificial intelligence, I think we'll augment our intelligence." And so I think that's the way we should view this, is augmenting our intelligence, augmenting our capabilities within the world of spine and spine research, for that matter. So to give an overview of what I'm going to talk about, there are a lot of challenges with adult spinal deformity surgery. We'll talk about these challenges. We'll talk about the potential that AI has in spinal deformity surgery. And then, you know, we all got to start somewhere. And today we're going to start with the basic principles of machine learning. And then we'll finish with some case examples where we use these readily available predictive models. So I have no financial disclosures, but after watching David's talk, I kind of want some. But just to give a little background, in 2020, Medtronic acquired Medicrea, and we oftentimes throw around the term Medicrea, but they're kind of moving to this unit platform, as they call it, and it's designed to support surgeon workflow in preoperative planning and kind of create these personalized implant solutions for surgery. And so we'll talk a little bit about that today. The case examples, and then a lot of the presentation does have to do with Medtronic's unit capabilities. So the challenges of spinal deformity surgery. You know, there's so many variables that must be considered when planning a surgery, and everybody's treatment algorithms can vary significantly. I mean, just the 3 presenters before me, we all kind of view problems in a slightly different way. You know, when you think about the surgical pathology, patient signs and symptoms, their entire skeletal anatomy and alignment, each segment's mobility and anatomy, the different biomechanical forces depending on their body habitus, patient's bone density and composition, a patient's desired goals, how much they want to go through, their comorbidities and limitations, and then your own experience as a surgeon. I remember grand rounds. I gave a grand rounds on cervical deformity, and a neurologist was like, "Well, can't you just design a study and test these things?" And I just thought that was so ignorant when it came to spine surgery. And no, it's, you know, up until I discovered this technology, I was kind of disenfranchised by the whole academic world because it seemed almost impossible to isolate these variables and study them effectively. This is spinal deformity. There's some parameters and things, but a lot of it is just somewhat of an art form. But I think with the budding of this artificial intelligence technology, we are going to be able to study all these variables and how they relate to each other. So what is the potential? So AI seeks to replicate the experience of human intelligence. It's able to learn from immense data sets. And, you know, all this stuff, Chris Ames out at UCSF, he's kind of he's definitely an early adopter in this. And I remember being in residency, hearing him talk, and he was talking about all this mass data they were collecting. And as a resident, I'm like, well, who's going to, you know, synthesize that data and dissect that data? Who's going to mine all that data? It's us, the residents, right? So I was not very excited about hearing about all this mass data collecting. But with mass data, you know, this was back before AI was kind of a buzzword. The AI analyzes all of it because humans aren't capable of analyzing this much data. So AI seeks to learn from just immense data sets, help make decisions and provide recommendations, and then it can adapt to new data readily. So there's various aspects of AI. There's natural language processing, robotics, computer vision, but machine learning, I think, is the kind of the key aspect here that we're implementing in our field. So this is a quote from that paper I just showed. The opportunities are limitless in what questions may be answered beyond the scope of our current knowledge base and human limitations. Spine surgeons have historically relied on clinical judgment and experience, in addition to retrospective cohort studies based on linear and logistic regression, to educate patients and inform their decision-making. So kind of this primitive model into just limitless potential. I think this is going to revolutionize our ability to conduct research in spinal deformity. You know, we typically will try to think of what variables affect patients, but artificial intelligence will be able to look at other relationships that we're not thinking about and able to analyze this massive amount of data. This helps reduce user bias, and we can, you know, analyze everything without leaving anything out. So if you can imagine all the variables you look at in a spinal deformity patient: age, sex, bone density, body habitus, BMI, alignment, you know, you have all this data. And then when you look at outcomes over the long term, AI will be able to tease out what matters and what doesn't. So kind of in general about the potential, artificial intelligence has the potential to be all of our collective experience, so that in the future surgeons, any experience level, can use that to guide their decision making. So machine learning. There are three paradigms of machine learning, and I think this is just a great place to start if you have no background in this stuff. The first is supervised learning. So supervised learning, it uses labeled data sets to train algorithms to predict outcomes and recognize patterns. So what that means is that the data is labeled and that it contains examples of both inputs and correct outputs. So let's say, for example, you feed into the machine pictures of various trees, and you label those trees. This one's an oak tree, this one's a maple tree, this one's a arborvitae. And it learns from the input. Then you start sending it data that's not labeled, and it has already determined which characteristics make it this tree, which characteristics make it this tree, and it spits out kind of an answer. So here you can see rectangles, circles, triangles, hexagons. These shapes all have a label. Once the machine kind of learns this pattern, you can send in unlabeled data and it can spit out answers. So the application in spine surgery would be show the algorithm a full-length Scoli X-ray, and the machine that has kind of already learned will be able to calculate bone density. It'll be able to calculate lumbar lordosis, PI, and just kind of do it for you. The next aspect of machine learning is unsupervised learning. So this is where the models are given unlabeled data and they're allowed to kind of discover patterns and insights without any explicit guidance or instruction. It kind of makes up its own rules and can kind of structure the information based on similarities, differences. And so kind of using the same example, you have a bunch of shapes. Now it doesn't know what these shapes are, but it can kind of spit out that these are similar, these are similar, these are similar. So when you apply that to spine surgery, you could have a whole bunch of patients who have undergone a one-level fusion or a T10 to the pelvis and have certain outcomes. And so that machine learning could potentially take all these patients and their outcomes and group them. Turns out that patients with lower bone density have higher rates of hardware failure. You know, we know that through our research, but this is what they could take on a whole nother level. Patients over the age of 65 who happen to be female, who happen to have a DEXA score of -1.5 and carry their body mass anteriorly are going to get 50% of the time PJK. You know, whatever the example is, but they'll be able to kind of pool these variables together and find out what are problematic combinations and what are ideal combinations of those variables. And then reinforcement learning is very similar to the way humans learn, and it takes actions in a dynamic environment through trial and error to maximize the collective reward. So this is where you provide positive or negative feedback, and then the algorithm can kind of learn from that. So this is very important, I think, in the development of this technology. You know, when I show the, you know, this technology and what I have been using, you know, so far the outcomes of the AI may not be all that impressive, but every time you utilize the application, you are giving it more information so that 10 years down the road, you've got all these surgeons pumping in all this data that's being mined by whoever created the algorithm, and the algorithm gets better over time. So just to kind of recap, if you don't learn anything at all about AI machine learning, just know that there's three aspects: supervised learning, unsupervised, and reinforcement. So now if the whole world of AI and machine learning and how it applies to spine seems foreign and too much, you know, you just got to start somewhere, and this is a great place to start. So the UNID platform is Medtronic's AI platform, and I think David's slide, looking at the different companies and how they've evolved in their market cap. Right now, it seems like Medtronic and Globus NuVasive are really kind of leading the charge in some of this newer technology. I know Diffuse Synthes is like a third, and they've got stuff coming out. But this really is kind of a first mover advantage as you start collecting this data and building these algorithms. So the UNID platform is more than just AI. It starts with this kind of team of biomedical engineers where you see a patient, you come up with the plan, and then you send your plan to these engineers. What they will do is they'll utilize their software to kind of chop up the Scoli X-ray and make the adjustments that you said you would. Say, for example, I'm going to do an L5S1 ALIF. Well, they'll chop the image at that, add 15 degrees, and they'll kind of create this pre-plan. And then they utilize the algorithms to predict the outcome. And on the next slide, I'll tell you about those algorithms. Once the kind of plan is finalized, they create this patient-specific implant. And the reason for this, as Dave was talking about earlier, is a way to sell it. But I do think, these prefabricated implants are kind of nice, and I'll show some examples of why. Because when you get into surgery and you've got these big plans on correcting sagittal balance, it's really hard to kind of check yourself intra-op and say, are you doing exactly what you said you were going to do? And then after surgery, there's post-op analytics on, did you do what you said you were going to do? And then did the rest of the spine change the way we predicted? So here are the three algorithms that the UNID platform has. And the one I'm going to talk about the most here is this adult deformity. So this algorithm is supposed to predict that at 6 months post-op, what the thoracic kyphosis will be and what the pelvic tilt will be. How important pelvic tilt is and thoracic kyphosis. I mean, PJK is our glioblastoma, our holy grail, trying to figure this out. In the PEDS world, their algorithm looks at lumbar lordosis and pelvic tilt at 12 months post-op. Now, these are scoliosis cases where they're usually not fusing down to the sacrum. And then they also have an algorithm looking at degen cases, and at 6 months looking at lumbar lordosis of the upper non-instrumented segment, and then sacral slope or pelvic tilt. So this team of biomedical engineers kind of has this generic understanding of alignment, but you can really work with them as much as you want and let them know what's important to you. Are you just sticking with the basics? Do you have different ideas about what you think proper alignment is? And it's a very personalized experience for the surgeon. So I'm going to move on to some cases, and these are fine cases. They're not like the best outcomes, but I think they really illustrate the technology and kind of what we were able to do with them. So this first case is a 50-year-old woman with a history of L4-5 fusion, and she presented with complaints of sagittal deformity, inability to stand up straight, inability to walk any significant distance, just overall quality of life severely diminished. So there's just a one-level fusion. It's not a completely fixed deformity, but my plan here was an L2 to 4 L lift, and then an L5 S1A lift as a stage 1, and then from the back L2 to 2, 3, 3, 4, and 5, 1 grade 2 osteotomies with T10 of the pelvis. So I send that to the biomedical engineer team, and this is what they churn out. They basically measure every end plate, and they kind of come up with an alignment. And just to backtrack, these algorithms are only built on alignment. They're not taking into consideration anything else. They're not considering patient's age. They're not considering bone quality. They're not considering the facet anatomy or the flexibility of the curve. It's literally just looking at alignment, which I think is so inadequate. And I've kind of talked to them about, we're collecting all this data up front, and surgeons are using this. I mean, we should really be collecting every aspect of any data that we can collect on these patients. We should be getting after it immediately. If you're going to have a team of biomedical engineers working on this, I mean, you can hand them a DEXA score. You can hand them the patient's sex, male or female. You can hand them the age. Just simple data that is all readily available. So going back to this first case, so here's the preoperative plan, and just kind of from a bird's eye view, looks nice, and you can see the pre-op measurements, the plans measurements, and kind of the perceived correction at every level. It kind of gives you some advice on what angle of implant to use, and then again, it pre-manufactures the rod. So on that kind of pre-manufactured rod, I do want to say one thing. When I look at the hospital that I do these surgeries at, this cost of this whole platform and the pre-manufactured rod chews up about 2/3 of the hospital's margin on these cases. So they're not really telling me I can't do it yet, but it's kind of always in our best interest to try to create value and keep costs down. And so one of the future possibilities here, and I've talked to the people at Medtronic, is is not actually giving you a pre-manufactured rod, doing all of this, but then giving you a sterile template that you can bend your own rod to, and that wouldn't be very hard. And that cuts the cost by about 75%. And makes and at the hospital where I'm using this, it would make the cost of all of this about the price of a pedicle screw or two, which I think would really increase adoption. So post-operatively corrected in the coronal plane, corrected in the sagittal plane. The thoracic kyphosis was a little bit higher than it had predicted. But then again, this kind of goes back to inputting this data into the algorithm for future algorithms. One thing I really like this for is, when you're doing a coronal correction, a lot of times people don't have, it's not the worst sagittal deformity you've ever seen. And you can find yourself, as you're loosening up the spine, the patient sinking into that Jackson table, you can find yourself overcorrecting in the sagittal plane quite often. So I think this is kind of nice if you really want to loosen up the spine, give you kind of an end vision for the sagittal correction. Now here's the kind of the 3-month post-op, and already seeing some increased kyphosis. And I don't have the 6-month post-op here. I haven't had it in the sheet, but she's straightened back up. So, what does the thoracic spine do in that first year? We're maybe not collecting all of this. We think maybe it's just going to tip over. We do, it's been shown that people actually, as their muscles improve, they start to stand up taller. So kind of measuring that, I think, over time would be interesting. Here's another case, 56-year-old man. He had a 5-year history with complaints with his deformity, inability to stand up straight. He had bilateral S1 radiculopathy, inability to walk with severe pain, quality of life diminished. So looking at this, it's like, how did this happen? How did we get here? And this was done by a non-deformity surgeon in the community. So I had to go back to 2018 and find, what was the original scoliosis x-ray? And, if you do some simple measurements, there was a slight PILO mismatch and a little bit of hypokyphosis of the thoracic spine, but it wasn't a terrible deformity at that time. And I think the surgeon got a little overzealous with the correction. Looking at these cages, putting in 18-degree cages and 12-degree cages on these levels that were originally relatively flat, he immediately developed compression fractures at multiple levels and ended up fusing. He's also got some really interesting anatomy. This is the original surgeon did a T12 to S1, but there's this mobile kind of S1, S2 vertebrae. He technically has 5 segments in the sacrum, so you could call it an L6 S1, but the S1, the S1 nerve root exited at this level, so it was I kind of just referred to it as an S1, S2 level. But the plan here was to do an S1, S2 ALIF with an L4 PSO and T12 to the pelvis. He had some pain at the proximal junction. And then, given his history of this subsidence and compression and the sacrum kind of being a soft bone, I decided to cement augment the S2 screws, if you will. So this was the plan, basically going to get correction at that bottom level and then a PSO. I wanted to utilize this software just to kind of get a second set of eyes on all these measurements and kind of put together a preoperative plan rather than going in the traditional way. So here's the post-op. So I probably got a little bit less correction from the PSO than the plan had told us, but the thoracic kyphosis was less because of the less correction. So this wasn't the most necessary case to use it, but for all the reasons we just talked about, I thought it gave some good information going into it. Now, this third case is actually the first deformity that I used the platform for, and it's what really made me a believer. And Jake's in the room over here. He kind of convinced me. He's like, let's just pick the hardest case you're going to do, and let's just give it a go and see what you can do. So this is a 72-year-old woman who presents with, the same sagittal deformity complaints. But she actually had a normal DEXA scan, normal bone metabolism labs. And as you can see from these films, this is a lumbar kyphoscoliosis. We typically think of deformity as a thoracolumbar problem, but this was such a tight deformity. And I don't know, I felt ambitious. I wanted to not just, necessarily get a little correction infused in situ. I wanted to fix the spine, make it look the way it should. Her ribs are sitting on the iliac crest. She's, for the last 20 years, been in so much pain that, lifestyle was dramatically influenced by that. So my plan was to kind of just approach it standardly, inner bodies from L2 to S1, and from the back, breaking everything up. And these were like legit grade 2, taking the ligament completely out, inspecting every single nerve root, because I knew that I was going to be changing things dramatically. I didn't want anything getting hung up or caught. And so when I did the surgery, I broke everything up, and we were using our Lanky clips, and it was just like a wet noodle coming to the pre-manufactured rod. It was one of the most amazing things I've kind of witnessed, and just kind of blew me away that it was able to work. So here you can see the preoperative plan, quite ambitious in the sagittal plane. If you look at that diagram to the right, to be able to in a 72-year-old loosen everything up. But indeed we did, and it had me as a believer in this technology and what we're able to do. So if we didn't have this pre-planning and the pre-manufactured rod, like, you go into surgery and you want to restore everything, you want to break everything up, how are you going to know intra-op if you kind of did exactly what you did? Now, we do have 36-inch X-rays intra-op. So with all of these, especially with the coronal deformities, I'm trying to make sure that we haven't accidentally sent them one way or another. But this was really powerful. Now, you may see I used to be a huge believer in these sublaminar bands. And in this patient, she was treated with a spinal cord stimulator. And I didn't really take these into consideration. But, further dissecting for sublaminar bands and kind of disrupting the posterior elements, and then having a previous spinal cord stimulator where the musculature has already been dissected and a laminectomy has already been performed, I kind of left a very vulnerable mid-thoracic region. So, over the next year, she kyphosed at that level. But this was a pretty simple extension up, and she completely bounced back to where she was. I mean, this is one of the happiest patients I have, and with their kind of renewed zeal for life, are traveling the world and doing all the things that they couldn't do over the last 20 years. So, yeah. Well, that's what the future holds here. But I think, this is problematic, because now the algorithm thinks that if we correct somebody like this, we're going to get PJK, and it's just one patient, but there are so many other variables that resulted in this PJK, most of it iatrogenic. And so, I just think that we have such a long way to go with this. But as you can see, AI is talked about in every industry, and it's not robots with their own intelligence doing spine surgery. It is that more augmented intelligence. And if it seems intimidating, we are literally on the ground floor, and it's going to be part of the future. So I think it's worthwhile to get involved, because that's really how you'll learn. But yeah, machine learning, and it's our collective experience. Thank you very much. You guys have any questions?